All right, so we'll go ahead and get started. So thank you everyone for joining us today for the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So thank you in advance for muting your microphone once the presentation begins, being attentive to the presenter, engaged in the session, keeping your camera on when appropriate, registering for receiving credit for each session, and completing and submitting a session eval form. Next slide, please. It looks like this is missing the code, so I will add the code in the chat for this, but this is how you get the CME credit. So I will just update it and add the code for everyone. So next slide, please. Sorry about that. Next slide, please. And this is how you get your CME transcripts. Next slide, please. And then this is just information regarding the AAFP credit system. Next slide, please. And these are the core competencies that we will address. Next slide, please. And then this is a conflict of interest statement. Rachel Walters has no financial relationships with ineligible companies to disclose. Next slide, please. Is this the one that Kelsey sent you? Sorry, it looks like it's missing everything. Is this the... Does it have your presentation at least? Sorry, because it's missing all the stuff that we have for our intro.
Let me check really quick.
Okay.
Okay, I'll share. I think I have the right version now.
Okay, thanks. This will just have that CME credit, all that stuff for them that we add to the slides. Yeah, this one's the right one. Okay. Yeah, if you leave it here for a second. So sorry, everyone. So this is the activity code for today, April 10th. So to get CME credit via text, just text your email address to that toll-free number and then attend and 10093244. So I'll leave this up here for a little bit so you can all get credit. All right, and then next slide, can go through these next ones since we did all that. Yeah, next one, next. Okay, there we go. All right, so Rachel, take it away.
You're muted.
Rachel, you're on mute right now.
Thank you, Elliot.
You got it.
Yes, I'm a psychology resident here, completing my internship with UT Health at UT Health San Antonio. I'm a part of the integrated primary care track, but I have a special interest in eating disorders. I completed a year-long clinical rotation at an eating disorder treatment center, and so it's definitely something that I'm really interested in. I'm really excited to be able to talk about with you guys today. So my presentation for today, eating disorders, specifically in primary care treatment. So our learning objectives for today. So first, being able to define the criteria for the DSM-5 eating disorders, describe the eating disorder stereotype and how it impacts various populations, learning how to assess, diagnose, and treat eating disorders in primary care, and then being able to describe 3 behavioral health interventions. So these are the 6 big eating disorders in the DSM-5. So you have anorexia nervosa, bulimia nervosa, binge eating disorder, other specified feeding and eating disorder, avoidant restrictive food intake disorder, and rumination disorder. And so I'm going to go over each of these with you. So first we have anorexia. So this is probably the one that I would guess you guys are most familiar with in terms of like the different criteria. So first you have the restriction of energy, energy intake relative to requirements, which leads to low body weight. The DSM says low body weight, but then it does specify that for adults that is a BMI of 19 or less than 5th percentile for a child. They also have an intense fear of gaining weight or becoming fat, or they have persistent behaviors that interfere with weight gain. And then there's also disturbance in the way that their body weight or shape is experienced, a very heavy influence of body weight or shape on their self-evaluation, or a persistent lack of recognition of seriousness of one's illness. Something that I learned recently was that, so if you look at the genetics for schizophrenia, there's actually overlap with some of the genetics for anorexia nervosa. And so if we're thinking about the perceptual disturbance, I think it's really interesting to consider that I mean, obviously there's a lot of perceptual disturbances happening in schizophrenia, but we're seeing that similarly might be happening with anorexia. So whenever they are looking at themselves, they literally are not seeing themselves the way that we are seeing them. Oh, and then you also can have, there are 2 subtypes of anorexia, and that is restricting subtype or a binging and purging subtype. Okay, next is bulimia nervosa. So with this, there is the binge eating, and then there is the compensatory behavior. So for binge eating, that is eating within any 2-hour period an amount of food that is larger than what most individuals would eat in a similar circumstance, and also a feeling that one cannot stop eating or control how much one is eating. There's also research with this specifically that the feeling of lack of control is what is most predictive of outcomes. If you have someone and it doesn't really sound like they're eating what you would consider to be a very significant amount, but they're describing feeling, you know, a lack of control around their eating, not being able to stop how much they're eating, then I would say that it would still count as a binge, because that lack of control piece is what's most predictive of outcomes. And then with bulimia, there has to be that inappropriate compensatory behavior, and that's specifically to prevent weight gain. So this could be anything like purging, it could be misusing laxatives or diuretics, it could be misusing insulin or diabetic, or it could be excessive exercise or restriction. And then this also has the influence of body weight and shape on how they evaluate themselves. And then it has to occur for at least once a week for 3 months. Next is binge eating disorder. This is one of the newer eating disorders. So this is just the binge eating criteria. So they have the episodes of binge eating. They're associated with 3 or more of the following. So eating much more than normal, eating until uncomfortably full, eating large amounts of food when not physically hungry, eating alone because of feeling embarrassed or feeling disgusted with themselves afterward, or very depressed or guilty afterward. Again, this is the same thing where, yes, the amount that is eaten can indicate a binge eating disorder, but also again, it's the lack of control piece that is most predictive of outcomes. So next we have avoidant restrictive food intake disorder. So this is similar to anorexia in that it is leading to significantly low body weight, and they are restricting the amount of food that they're eating. However, this is not associated with trying to alter their body, or not associated with doing it for the purpose of losing weight. So there is some type of feeding disturbance, but that could be due to just lack of interest in eating or in food, avoidance based on secondary characteristics of food. So things like if they don't like textures or certain colors of foods or certain smells of foods, or also concern about aversive consequences of eating. So if they have, if they have a very sensitive gag reflex and they're afraid that they're going to vomit whenever they eat, something like that. It also has to lead to either significant weight loss, significant nutritional deficiency, dependence on tube feeding or nutritional supplements, and also or interference with psychosocial functioning. And the practice, it can't better be explained by culturally sanctioned practices. Next is rumination disorder. So this is repeated regurgitation of food over a period of at least 1 month, and the regurgitated food can either be re-chewed, re-swallowed, or spit out. It cannot be better attributed to an associated GI or other medical condition. And again, if it's occurring, it can't be occurring exclusively in the context of another feeding or eating disorder. And then lastly, there's other specified feeding or eating disorder. This is kind of a catch-all diagnosis for when someone is not quite meeting criteria for another type of eating disorder, but they're engaging in some type of disordered eating and it's impacting them in a functional way or causing significant distress. So different examples of what this might look like could be atypical anorexia nervosa. So someone is basically meeting all the criteria for anorexia, except they're not quite at that significantly low weight. Both for bulimia or binge eating disorder, they could be engaging in those behaviors. Maybe it's just it's not meeting like the frequency that it has to be occurring at in order to meet that diagnosis. Purging disorder. So if someone is only purging and they're not engaging in any type of binge eating, and then night eating syndrome. So I want to talk about eating disorders specifically in primary care. So PCPs play a very important role in treating eating disorders. That being said, we also know that physicians report limited knowledge or comfort treating eating disorders, even though this is oftentimes the first time that patients are talking about their eating disorder, or the primary care is the first stop towards getting an eating disorder diagnosis. Because we do see that individuals are likely to first present to PCPs when they have eating disorders. If you look at the people who are diagnosed with eating disorders, about 50% of adults specifically were being diagnosed by their PCP. So we're seeing that in primary care, we're playing a very important role of being able to have a good chance to identify those individuals. That being said, delayed diagnosis is very common. So up to 80% of people with eating disorders go undetected or never receive any type of treatment at all. We know that obviously there are some significant difficulties in identifying eating disorders. So one study found that health providers accurately detect only 10% of individuals with an eating disorder. And so that kind of matches up with the 80% going undetected, you know, kind of in the similar ranges. And so here we're seeing that we're at a good place to catch these people whenever the disorder is first developing, but we have some steps to take in order to identify everyone. Part of the reason why early treatment is so important is that one, it's just one of the most important factors for full recovery when treating eating disorders. So studies have found that the longer that someone has the disorder and they don't receive treatment, once they do finally start treatment, the less efficacious the treatment actually is. So someone that has anorexia for 1 year versus 5 years, the person who has only had it for 1 year and they start treatment, the treatment is likely going to work better compared to the person who had the disorder for 5 years. We also see that as the disorder progresses, that there's also increased mortality rate as well. And then these are just some the average length of untreated eating disorders. So for anorexia, it's over 2 years. For bulimia nervosa, over 4 years. Binge eating disorder, over 5 years. And when we're thinking about treating eating disorders, it is very well known for being a very difficult types of disorders to treat. And so average length of recovery can take around 9 years. And so the longer that we put off diagnosis, the longer these individuals go without treatment, which means the less efficacious the treatment is going to be once they finally do get it, the more risk for mortality that they have, and then they still have the average of 9 years of recovery to happen. So it's really important that we're able to detect those individuals as early as possible. So one way we can help to do that is by improving awareness and recognition in primary care to help facilitate that early treatment that we know is so essential to treating eating disorders. But in order to do that, we also have to talk about an area of eating disorders that can impact that. And so one of those things is the eating disorder stereotype and the way that we typically think of eating disorders. And then I've also, I think this is also kind of played out here as well, where, when talking about this, because this area is an area of interest of mine. And so, if you have rotated with BHC, then I've probably talked to you about this. But I've heard some people say, well, oh, other people say, well, these aren't really our patients. These are our patients in the clinic. That's not the patient population that we're seeing. And so I hope by the end of the presentation that you will start to question that and think of that in a little bit of a different way. So going back to that eating disorder stereotype, I want you to take a second, imagine someone with an eating disorder. So imagine what they look like, imagine, the characteristics that they have. I really want you to visualize, if you could, describe what someone with an eating disorder looks like, what would this person look like? So thinking about the stereotype, we know that the stereotype does exist. And so when you were thinking about this person, this is probably the person that you thought of, like many people are going to think of as this person. So the stereotype for someone with an eating disorder is someone who is thin, young, white, wealthy, and a female, a cisgender female. And this has been perpetuated by mostly everyone. So it's been perpetuated by psychological research. This is mostly who we were doing research on when researching eating disorders. And this is still an issue to this day of lack of diversity in eating disorder research. This is perpetuated in the medical field when, these are the people who are getting diagnosed with eating disorders. It's perpetuated by media. This has been very heavily perpetuated. And because of that, it has shaped the way we approach, assess, diagnose, and prevent eating disorders, because we're basing everyone who has an eating disorder as, well, this is what they look like. So every single person who doesn't look like that isn't getting a diagnosis, isn't getting treatment. So now I'm going to talk a little bit about how that eating disorder stereotype can impact various populations. So the first that I wanted to talk about is how it can impact people of color. So despite the fact that people of color experience eating disorders at similar prevalence rates, they're half as likely to be diagnosed and to receive treatment. And this is despite the fact that actually both Black women and Hispanic women are more likely to present with bulimic behavior or with bulimia nervosa. And so even though they are more likely to experience those things, they're still half as likely to be diagnosed. Specifically, youth of color, they are less than 2/3 as likely to receive treatment. So we're seeing this happen both in adolescents and in children and in adults. Part of this can be due to bias on the individual's own bias. So thinking to themselves, well, I'm not the type of person who gets eating disorders. That's a disease for white girls. That's not me. But also part of that is provider bias as well. So we see that if two people versus if one is Black and one is white, if they are complaining about the same type of eating concern to a physician, the Black individuals are significantly less likely to be asked about those eating concerns by physicians compared to the white individuals. We're less likely to inquire about eating concerns when being expressed. This also happens with behavioral health clinicians as well. So clinicians are less likely to recognize eating disorder symptoms in people of color. This study was actually very interesting. So they did 3 different vignettes. They were the exact same. The person had the exact same name in it. The only one that was different was the race in the vignette. And when people were given the vignette of it was a person of color, they were significantly less likely to diagnose them with an eating disorder compared to the exact same vignette with the exact same name. They just happen to be white. The eating disorder impact on eating disorder stereotype impact on larger bodies. So the stereotype is that, it is, they're thin, obviously with anorexia. I mean, it's literally a part of the criteria, right? Is that you have to be significantly underweight. But actually only 6% of individuals with eating disorders are diagnosed as medically underweight. So only 6%. That means that 94% of individuals are not underweight. Actually, people with larger bodies are at a higher risk of developing eating disorder behaviors. And we have found that as BMI increases, the risk for developing an eating disorder does as well. So actually, the opposite is true, that as BMI increases, risk of eating disorders, not the opposite. Despite the fact that they're more likely to present with those things, again, even when presenting with the exact same concerns, they're half as likely to be diagnosed with an eating disorder compared to if someone with with a normal BMI or someone who was on the lower side, if they were presenting with that same concern, they would be much more likely to receive that diagnosis compared to individuals with larger bodies. There's also, obviously, we know that starvation is not good for the body. Being at a very low body weight, that it's also not healthy for the body. In terms of severity and eating disorder severity, we tend to use weight as a predictor of severity of what their current weight is, right? So someone who is at a BMI of 17, that obviously we're going to think that is much more severe versus someone who is at a BMI of 20, say, but these behaviors as well. What we have found is that the current weight, it's not actually the best predictor of severity. What is a better severity is the amount of weight that someone has lost and how quickly they have lost it. And also specifically with anorexia, you can still have medical and cognitive effects without necessarily being underweight. So you don't necessarily have to be underweight in order for your brain to kind of go into like starvation mode, so to say. Next is the stereotype impact on the LGBTQ population and men. So we know that LGBTQ youth and adults are more likely to have eating disorders. Youth specifically are 3 times more likely to have eating disorders, and specifically transgender youth or other gender nonconforming individuals, they're 4 times more likely to have an eating disorder. And we know that there's also an increased mortality rate as well, where LGBTQ youth with eating disorder diagnoses, they're 4 times more likely to attempt suicide. Specifically in men, so again, this is typically thought of as a female disorder, but we know in men that there's still a 4% lifetime prevalence rate in men specifically. And actually what we have found is that the rate of eating disorders in men is increasing faster than it is in females. Again, just like every other group I've talked about, when men present with the exact same problem, they're significantly less likely to receive a diagnosis. Because men themselves, again, there's that kind of like internalized bias piece of it where, they might be telling themselves, well, girls are the one that gets eating disorders, that's not what I have. And so often what is found is that there is a delay of seeking treatment because they're not recognizing those behaviors. There's that stigma associated with it. And so what can happen is that when men do have eating disorders, it can actually be much more severe because, again, we're prolonging the period of until they are able to receive treatment. Next we have impact on low SES. So it is thought of as being like the wealthy woman's disease. There has been no association ever found between eating disorders and having a high socioeconomic status. What we have found is the opposite to be true. So eating disorders are actually rising at a faster rate for individuals with low socioeconomic status compared to high socioeconomic status. We also know that individuals with public insurance, they're 1/3 as likely to receive the recommended treatment. I don't think that's a surprise to anyone here. And specifically with food insecurity, that has actually been found to be associated with an increase in disordered eating. So both youth and adults who are experiencing food insecurity, they're more likely to develop bulimia nervosa and binge eating disorder. And so thinking about food insecurity in Texas specifically, so we know that 1 in 4 Black Texans, 1 in 5 Latino Texans, and 1 in 14 white Texans experience food insecurity here in Texas. And so here we see that these individuals are more likely to present with disordered eating behavior. And then also thinking about how being a person of color also comes into play with it, which again, they're more likely to experience those disordered eating behaviors, less likely to receive treatment, less likely to be diagnosed. And then lastly, with the stereotype impact, looking at older adults. So age does not immunize a person from having an eating disorder. In fact, eating disorder symptoms and body preoccupation has actually been increasing among middle-aged and elderly women. And then also remembering that eating disorders are typically chronic conditions. So even if someone does get it in adolescence, unless they are able to, get treatment quickly and be in remission for a long time, then odds are they're still going to be having some of those symptoms. When we're looking at eating disorder treatment and recovery over time, fewer half of people will ever fully recover. About a third will improve, but they're still remaining symptomatic. And then about a fifth of patients will be chronically ill for the rest of their life. So here we see that at least a fifth and a third of people, they're still going to be having these symptoms well into middle age. Into middle adulthood. Believe it or not, these numbers have actually improved. It used to be kind of a third, and a third was like the typical rule of eating disorder outcomes with recovery. So I hope while reading and looking at all of that, these things are popping up that the people who are most likely to experience eating disorders, who are less likely to be diagnosed and less likely to receive treatment, they are our patients. And they're the ones who aren't getting diagnosed and who aren't getting treatment. And so one thing that we can do is to work towards providing them with that diagnosis and treatment. And so let's say, if we were to just say, oh, well, if they if it's like low self-esteem, what's like the worst that could happen with eating disorder? Surely it's like not that big of a deal, right? But eating disorders are the second deadliest mental health condition. It was first until I want to say around like 2016, and then opioid use disorder became first. But out of all the different mental health conditions, it is second deadliest. Specifically, people with anorexia, about 10% will die as a direct consequence of having anorexia nervosa. And when you look at the suicide rates, about 44% of people with individuals will at least attempt at some point during the illness. So when these people aren't getting diagnosed and aren't receiving treatment, it can have very, very severe outcomes. In fact, in the United States alone, 3.3 million people will die from an eating disorder each year. So that's 1 person every 52 minutes. So by the end of this presentation, 1 person in the United States will have died as a direct result of an eating disorder. So what can we do? Like I mentioned earlier, here in primary care, we are in a very good spot to be able to identify these individuals early, get them treatment early, and hopefully improve those outcomes and decrease that mortality rate. So I'm going to be kind of going through, the assessment, how to screen for it, different information to give them, kind of walking through that kind of pathway of treatment for them. So here I have some kind of red flags. So these are some different things where if you have someone coming into your visit and you see one of these things, it might kind of, maybe you just want to inquire a little bit more about some of these things. So some of the medical red flags that I have on there is any type of rapid weight loss or gain, bradycardia, amenorrhea, or light and irregular periods, or GI complaints. And this is also in addition to all of the other stuff that you guys know as being associated with eating disorders. So if they are complaining about, being cold all the time and they're starting to get, the fine hairs on their face, or the swollen salivary glands, those types of things. Also, some behaviors to also keep your ears open for is any type of hiding, hoarding, or sneaking food. If they're talking about eating in secret, any type of feelings of guilt or shame around eating, dissatisfaction with body weight or shape, which is actually the biggest predictor of developing an eating disorder. If they're reporting frequent dieting, any type of experiences with weight-based stigma, and also wearing a lot of like loose or baggy clothing, which I know might be difficult because it's also kind of the style now. So also use your clinical intuition and judgment as well. So if you have someone, some of those things are popping up and you're starting to get concerned that they might be engaging in some disordered eating behavior, you can screen them. So universal screening is not necessarily recommended, but if you do have some of those risk factors or concerns that are being present, then screening is indicated. So one screener that is very fast and pretty quick to use is called the SCOFF. It's an acronym. So those are the different questions. So do you make yourself sick because feeling of uncomfortable? Do you feel like you've lost control over how much you eat? Have you lost more than 1 stone or 6.35 kilograms, which is about 15 pounds in a 3-month period? Do you believe yourself? Others say you are too thin, and would you say that food dominates your life? This is specifically really only going to be able to target anorexia or bulimia nervosa. When this was developed, I don't think that binge eating disorder was a disorder yet. And so someone can have binge eating disorder and screen negative on this screener, just as a disclaimer. But if someone scores a score of 2 or higher, then that is indicative of a possible eating disorder. Another a little bit more in-depth screener that you can use, this one is called the Eat 26 Eating Attitudes Test. It's 26 items. That's a self-report measure. You can use it for individuals who are ages 13 older. And it just asks a lot of different questions related to different types of disordered eating behaviors, different ways that body weight and shape might influence the way they think or feel about themselves. And a score of 20 or more reflects being at risk for having an eating disorder. With the Eat 26, behavioral health, we have a copy of that. So if you do have someone where you wanted to, because I don't know if it's available online, but if you had someone and you wanted to use it, then we would be able to provide you with that screener. So let's say you have someone, they have like screened positive, or maybe you're still not quite sure. So these are some other questions that you can ask to further assess if someone is experiencing an eating disorder. So the first is, how much does body weight or shape impact the way you feel about yourself? So again, this is really targeting that, like the over reliance on like body weight and shape and how it makes them feel about themselves. I have heard from people, if I were to gain 5 pounds, like it would be devastating. The way that they feel about their body is going to greatly impact the way they feel about themselves. How much of the day are you thinking about your body, weight, shape, or food? I've received answers like 95% of the day they're thinking about one of those things, or like percent of the day their mind is on one of those things. Especially when we're thinking about the effect that starvation can have on the brain. The more starved you are, the more you're going to be thinking about those things. So that can also be if they are underweight, that can also be an indicator of that as well. Asking them if they're engaging in any type of body checking behavior. This can look like a lot of different things. This could be touching, poking, or pinching any areas on their body. It could be looking in the mirror. It could be trying on certain clothes, or if they have like certain like articles of clothing that they will repeatedly try on to see if the way it fits has changed at all. Also weighing themselves repeatedly. If they diet or count calories, asking them how much is too much. Because you can definitely engage in counting calories without it necessarily being disordered, but are they trying to keep every single meal at, less than like 500 calories? Are they really trying to limit specific things that they're eating, or cutting out entire food groups? And the last is any rules or rituals around eating. So this could look like, I can't eat until X time during the day, or I have to stop eating before this time during the day. They eat in maybe like really small bites, so taking very, very small bites. If it's something like, say, like a granola bar, almost like crumbling it up and then eating those crumbs. Eating foods not in the way they were intended to be eaten. And so what I mean by that is, for example, I had a patient where they ate a banana with fork and knife. That's not the way that people typically eat bananas. So that would be one of those rules. Another rule is not eating everything that's on their plate. So let's say if they had a yogurt, they could essentially eat 99% of that yogurt. They have to at least leave one bite. That could be a rule that they have, whatever they're eating, they have to at least leave one bite left. They can't eat everything, or they can't eat 100% of it. Those are just some examples of what that might look like. As providers, I want to just emphasize how important it is to provide education on the disordered eating behaviors. So I would say the majority of the time, patients are not aware about the impact that the eating disorder behavior can have, both on their mental and their physical health. Typically what I've heard is that, maybe they start with a diet or they start some type of behavior, and then it just kind of snowballs from there. And sometimes they really don't even recognize that what they're doing is considered like a disordered eating behavior. And so I would really emphasize like the different ways that those behaviors can impact their physical health, especially when some of those impacts can be reversible. So, leading to infertility, leading to irreversible like bone damage, or if they start falling off the growth curve because of it. But then also the impact that it's going to have on their mental health as well. So engaging in those different types of eating disorder behaviors oftentimes makes anxiety and depression worse, especially if starvation is involved. That's definitely going to make anxiety worse. And so just making sure that you're talking to them about how those behaviors are going to affect their bodies and their brain. Just like if you have someone coming in for diabetes, you're not just going to say, okay, diabetes, take this medication. We need to talk to them about, okay, what is diabetes? Well, it has to do with your blood sugar. Your kidneys are involved. This is the exact same thing. Another thing that I would emphasize with someone who has an eating disorder is that the best medicine is going to be food. Regardless of what the eating disorder is, best medicine is food. And so I think sometimes, because these individuals typically are in a lot of distress, and I think with most people, you want to be able to fix it quickly, but establishing a regular mealtime schedule or re-nourishing themselves, that's going to be the best medicine to make them feel the best. Another thing I put on there is also making sure to inquire about weight loss methods before praising someone. So if you do have someone who is coming in for maybe they are working on losing weight, they're really, just they're trying to take care of themselves physically, and so they have lost weight. Ask about how they're doing it before you just automatically praise that weight loss, because sometimes what can happen is that if someone is using disordered eating behaviors, as they're losing weight, they're probably going to get a lot of praise from all the individuals in their life, from family members, from friends. Oh my gosh, you look so good, you look great. And so then we don't want to further add to that, which is then just further reinforcing those disordered eating behaviors, because they're already getting that reinforcement from people around them. We don't need to contribute to that. And then specifically for children and adolescents, you can look at the American Academy of Pediatrics, and they provide very in-depth guidelines and recommendations around screening for eating disorders, treating eating disorders, indicators for inpatient hospitalization, all sorts of stuff. They have a lot of great information in there. Next, I wanted to just talk a little bit about prescribing. So, for anorexia, a couple things can be used. So the first is olanzapine, which can be used for weight gain and like the obsession shots. Weight gain, there's good evidence for it. Sometimes it's a bit mixed, but it can help with regaining weight if they are underweight. With obsessional thoughts, because when your brain is starved, like I mentioned earlier, you are constantly thinking about this. In terms of evolution, it makes sense, because if our body doesn't have enough energy, we want to be motivated to go and seek out that food, seek out that energy. So your brain is essentially just constantly thinking about this, to the point where it's almost like it's almost like an obsession, as in like OCD. Like that's how obsessive those thoughts are, which is obviously very distressing. And so it can help a little bit with that. I think results are much more mixed though for the obsessional thoughts, but it can help with weight regain. You can also use SSRIs for comorbid anxiety or depression that's present. Specifically for bulimia nervosa, what's recommended is SSRI, but more specifically fluoxetine. And the recommendation is starting at 20 and then titrating up to 60 milligrams. And this can help for both the behavioral and the cognitive symptoms of the disorder. And then lastly, binge eating disorder. So using SSRIs again for the comorbid conditions like anxiety and depression. However, there's less evidence for this compared to psychotherapy for those things. And then there's also some evidence for using Vyvanse dosage between 50 to 70 milligrams specifically to help with appetite suppression. So that can help to regulate and decrease the number of urges that they're having. So if you do have someone who you have identified as having an eating disorder, then we need to work on building the treatment team, because like most things, we need to have different modalities coming on. So if you are the PCP and you have diagnosed them with an eating disorder, you have already completed this first step. Fantastic. Next, with behavioral health, when in doubt, BHCs, we can always step in to help. So we can help to assess the level of severity to help find the appropriate level of care. So if it's at a level where they're totally fine to stay in outpatient treatment and we're going to continue to see them, then we can do that. Or we can help to find other additional resources if they do need a higher level of care, like partial hospitalization, like inpatient or anything like that. The one thing that I do want to add specifically related to this is that I cannot emphasize the lack of resources that are available for behavioral health treatment for eating disorders. I actually was talking to Dr. Abai yesterday, and you look at people who are in private practice, I think she said around like 50% of them take self-pay. Definitely our patients cannot afford self-pay. I wouldn't want to afford self-pay. And so that is something to consider. Also considering the fact that the average treatment episode for an eating disorder costs around $80,000. Treatment is very expensive, which is extremely unfortunate, because when these people don't get treatment, it can result in death, very serious consequences. And so there is, even in Texas, there is a very apparent lack of resources. So sometimes this part can be frustrating. And it's definitely an area that we need to continue to grow in, but we can help find what is available to them and find the best solution. The last part, and I would say the essential part, an essential part of the treatment team, is referring to a dietitian and making sure that we are referring them to a dietitian who does specialize in eating disorders, because this approach is going to be different compared to a dietitian working with someone for diabetes, say. And so we want to make sure that they're qualified with someone to be treating someone with an eating disorder. So if it is someone with anorexia or with ARFID, they can help with refeeding. If it's more like a bulimia or binge eating disorder, they can help to develop a consistent mealtime schedule to help decrease the frequency of those disordered eating behaviors. But it is absolutely essential that we are referring to a dietitian. It's like if you have someone coming in for CKD or ESRD and we're not referring them for nephrology. It just doesn't make sense. If the disorder is centered around food is medicine, we need to get them to a dietitian. Alrighty, so the last thing that I'm going to talk about is 3 different behavioral health treatments. So I'm going to start with cognitive behavioral therapy. So this is very similar to the cognitive behavioral therapy that you learn about when rotating with behavioral health. So part of what we're going to be focusing on is reframing the distorted thinking that is happening. So these are different things, what that might look like. So if they're in the early stages of recovery, it could be looking at the pros and cons of recovery. If it could be, what is the evidence that an eating disorder thought is true? What if you are not perfect? What would that mean? So looking at the different types of cognitive distortions that are going on and trying to reframe those. And then there's the behavioral piece, or exposure. So this could be approaching fear foods. So if they have certain foods that specifically in anorexia that cause like a lot of anxiety, making a plan around eating those. It also could be trying to decrease body avoidance as well. And then another technique that I really like, but under the CBT umbrella, is externalization, which essentially it is you are kind of separating the eating disorder from the person's identity. So when I do this with someone, it is okay, it's the eating disorder is talking. What does the eating disorder say? I have them name the eating disorder. Sometimes people just call it ED because it works out very nice with the abbreviation, but I've also had other people give it a completely different name. But the idea is when you have this thought of you need to restrict, you need to binge, you need to purge, that's the eating disorder. It's not you. Those are two different things. It can also help to make sense of ambivalence in the early stages of recovery, because that can feel very confusing and difficult to hold those two different truths of I want to feel better. I don't want to feel this way. And at the same time, my brain is telling me that this is the most important thing that I need to do is to follow these rules related to eating. Next is dialectical behavioral therapy. So DBT specifically, the focus is on emotion dysregulation and distress intolerance. So the way that DBT views eating disorder behaviors is that they're essentially just being used as coping skills. They're just not very effective coping skills. So if you have an unwanted emotion, you can numb it with restriction. If you're having anxiety, you can have a sense of gaining control with restriction. If you're having negative emotions, you can soothe that with binge eating. If you're feeling guilty after a binge, you can resolve that very quickly by purging. So here we're seeing that it's basically just a tool to help manage those unwanted emotions. So the goal when doing DBT is we're going to be focused on increasing the use of effective skills while decreasing the use of disordered eating as skills. So some different things that might look like is urge surfing. So if you have the urge to restrict, or if you have the urge to purge, what would that be like just to sit with that urge, ride it like a wave until it decreases? Because eventually that urge is going to decrease. Self-soothing, finding different ways to attend to those emotions, engaging in problem solving, working on interpersonal skills, doing a behavior analysis. So what was happening, directly before the purge, what was happening earlier that day, any factors going on that made you more likely to purge, that kind of thing. Excuse me. A very specific form of DBT is RODBT, or radically open DBT. This is specifically for individuals with anorexia nervosa. So DBT kind of views control as a spectrum. So there is under-controlled individuals and over-controlled individuals. So under-controlled individuals, people who might have more difficulties with impulsivity, that is going to be more so in like the purging and binging behaviors, whereas over-controlled individuals is more so where like anorexia lives. So these individuals are typically hyper-perfectionistic, a lot of social isolation, and a lot of risk aversion. So opposed to kind of like regular DBT, where we're focusing on emotion dysregulation, this is focusing on developing social connectedness. So from this standpoint, that's kind of like what is resulting in those different types of disordered eating behaviors. And then lastly is family-based interventions. So I would say if the patient is below 18, then this is absolutely required for treatment. Even if they're above 18, still recommended. So family-based interventions or family therapy. So externalization can also be very helpful with this as well. So again, viewing the eating disorder as a separate entity. so the patient is not the problem is the problem. I think this can be especially beneficial when if they are engaged in any type of like higher level of care, because it can cost a lot of money, it can take a lot of time. I mean, lot of the family's activities and their entire schedule can be centered around the eating disorder because it does take so much time sometimes. And so just reinforcing that it is not the child that's the problem, it's the eating disorder that's the problem, and those two things are two separate things. And then family therapy in general, how it can be helpful. So addressing other comorbidities or issues related to the eating disorder behavior, addressing dysfunction in the family system. So how are mom and dad, how are they interacting, or how are guardians interacting with the patient that might not be beneficial? What are some of the other systems or other things going on that might be contributing to this as well? And then it can also help parents with meal supervision. So helping them to try to find like what's the best thing to do if they notice that they're restricting, what's the best thing to do if they notice that, you know, they think they might be purging or something like that. All right. Any questions? I know I talked a lot.
There's a question in the chat.
You have one in the chat box.
The question is, how do we give weight loss advice to patients without encouraging disordered eating behaviors?
I think that is a great question. One thing that I really like to reinforce is reinforcing the behavior. So for like healthy weight loss, reinforcing the healthy behaviors themselves, not necessarily the weight loss, because you can lose weight without eating healthy. You can lose weight without exercising. You lose weight in unhealthy ways. So we don't want to be just reinforcing that piece. We want to be reinforcing how they're doing it. So are they eating a diverse range of foods, including, you know, whole grains, fruits, vegetables, healthy fats, all of it? Are they engaging in exercise that makes them feel energized, that makes them feel good, where they feel strong? And so reinforcing the behaviors that you want them to continue doing, not just reinforcing the weight piece. I think that can be a way to kind of get away from not accidentally reinforcing those things or reinforcing the wrong thing, I guess.
This is a really good presentation, Rachel.
Thanks.
Thank you. Yeah. One thing is, so on a overnight shift with Carmela and Daniela, in like the slides, how you're saying like the stereotypes and like what we typically think and all that. And we had one of the most interesting patients I've seen, and was like a type 1 diabetic and chief complaint like hypoglycemic and PO intolerant, stuff like that. But from the surface, it probably looked like that. But you know, of course, Carmela did like a really good with like asking questions, and but this patient, not without him saying, and he was like 60 years old, pretty much had like I would say like anorexia nervosa or like body dysmorphia, and not just with his eating, but would like overuse his insulin to, you know, stay really low. So his was more of like an obsession with like blood sugar. But he also, like when he was young, was like a bodybuilder. And so it was like kind of a very complex picture, but definitely like not what you would expect if you didn't kind of dig into it.
Yeah, exactly. I think that's also a really good example of those type of like compensatory behaviors that you don't typically think of. So misusing insulin can absolutely be a compensatory behavior. It's just typically not one that comes to your mind when you first think about it. But yeah, that's a great example. Any other questions? Alrighty, if not, oh, yes, I see a hand.
So, so if we're to fix on behavior, that's a way of reinforcing the appropriate changes. How do you measure progress if you are defocusing on weight loss?
So I think we don't necessarily have to completely ignore weight, or not talk about that at all. I think we just want to be very intentional and purposeful about not blindly reinforcing it. So if we're seeing weight loss, okay, good. They're losing weight, so that's awesome. Not going to inquire more. We want to be sure that you're, talking about how they're doing it, and if they are engaged in, appropriate behaviors, just returning it back to those behaviors, because you can also be a normal weight and be unhealthy. Just because you are a normal weight doesn't mean that you're automatically healthy. You can still be engaging in very unhealthy behaviors. And so we want them to be at a healthy weight because they're engaging in the healthy behaviors. So it doesn't mean that you necessarily ignore the weight piece, but it's like the way in which they're getting there. We would just want to be sure that we're reinforcing the appropriate things and reinforcing the appropriate behaviors with it.
So how concrete do you get in terms of asking about food, for example? You say, how many fruits and vegetables are you eating every day? And if you're talking about physical activity, are you talking about how many steps are you walking, or how much time? I'm weight, it's kind of easy because it's there in front of you, but what are shorthand ways of measuring that?
Yeah, I think asking so in like mindful choices, for instance, we do like a 24-hour food recall just to get a good idea of like what their typical like daily intake might look like, asking about the amount of like fruits and vegetables that they're getting for sure. One thing that I've learned is that adults just really don't like eating their fruits and vegetables. Asking about what type of physical activity that they're engaging in, especially if this is someone who's coming back and like you're working with them for the purpose of losing weight, then hopefully we're inquiring about those things anyway. But if I have someone where, it is in mindful choices, they are wanting to lose weight and they're talking about maybe they have lost weight, what I always bring it back to is like, oh yeah, and what I also heard from you is that you've been a lot more active, which was a goal of yours. You're feeling a lot better. You're having more energy. So even if that weight loss is present, reinforcing it to some of those other things as well, like the increased energy, feeling good, due to the activity that they're engaging in.
Thank you.
Thank you. Any questions? I think I'm almost at 1:30 anyway. Oh, just kidding. Oh, thanks.
Hi, Rachel. This is
Yeah.
Yun. Might have missed the beginning. So how prevalent are eating disorders in Hispanic population in our area?
I don't know specific prevalence rates for Hispanic women. I know the general like lifetime prevalence rate is around like 9 to 10% of people. So for anyone, around 9 to 10% of people at some point in their life are going to develop an eating disorder. I don't know off the top of my head those specific prevalence rates in those individuals though.
Have you guys been consulted or you helped diagnose some patients in our clinic?
Yeah, I had a patient, a 3-year-old, who presented for picky eating, and we ended up diagnosing him with ARFID because he was at a pretty significant low weight and had an inability he really wasn't gaining weight since for a couple years. We saw someone that we diagnosed with other specified feeding eating disorder. He was also at a pretty significantly low weight and just had so much anxiety around food that he was unable to gain weight. I've had other individuals where just because of some of these other things that they're mentioning, inquiring about some of those eating behaviors, and even if they're not quite meeting criteria for an eating disorder, still definitely engaging in different types of disordered eating behavior, like restriction because of feeling bad after eating a lot, engaging in binging, using compensatory behaviors, that kind of thing.
Thank you.
Thanks. So if you only take away 3 things from my presentation, I hope you take away that eating disorders are serious conditions that do affect everyone, that as PCPs, you're in a fantastic place to help aid in early detection, and that eating disorders are also treated by a team. So don't take on that entire burden by yourself, build a treatment team and improve outcomes. Thank you much.